Good evening. Good evening, everyone. I wonder if people at the back may want to move closer down so we can have more of an intimate, interactive session. You're free, of course, to stay where you are, but I welcome anyone who wants to move closer to the front. My name is Craig McClure, and I'm the Chief of HIV and AIDS at UNICEF, headquarters in New York. UNICEF is a key partner in the UN system, working with countries to accelerate voluntary medical male circumcision for older adolescents and men, and increasingly supporting countries to plan for scaling up of early infant male circumcision. I wanted to take a moment to acknowledge the absence of my co-chair, Kate Hankins, dear friend and colleague for many years, who was on her way to attend the conference and then urgently needed to return to Amsterdam, where she is Deputy Director of Science at the Amsterdam Institute of Global Health and Development. The Global Health and Development Institute in Amsterdam lost its director, Joep Lange, his partner, Jacqueline van Tongeren, who is also Director of Communications. And just to acknowledge their loss, the loss of all others on the Malaysian Airlines flight. And she wanted me to give her warm regards to all of you and her regrets. She's back in Amsterdam supporting the staff in this time of loss. We're here tonight to talk about some of the key programmatic challenges in the acceleration of voluntary medical male circumcision for HIV prevention. We're going to look at some of the cost issues, demand creation issues, some efficiency challenges, and quality of services. The way we structured the next 2 hours is in two halves, if you like. We'll have 4 speakers in the first hour and some time for questions and interaction with the panel. That section will be really looking at highlights from a recent collection of studies published in PLOS. And then the second hour, we'll look at some of the issues around VMMC and EIMC modeling. And again, have 3 speakers and then more discussion and interaction. So without further ado, I would like to introduce our first speaker for the evening, who is going to give us an overview of the state of the VMMC program, including costing issues. That is Emmanuel Njumeli, who is a Senior Biomedical Prevention Advisor at the Office of HIV and AIDS at USAID in Washington, and co-chair of PEPFAR's Male Circumcision Technical Working Group. Dr. Njumeli holds a medical degree from the Faculty of Medicine and Biomedical Sciences of University of Yaoundé in Cameroon, is a Master of Public Health from Johns Hopkins Bloomberg School of Public Health, and a Master of Business Administration from Johns Hopkins Carey Medical School. Dr. Njumeli provides technical support to countries in Eastern and Southern Africa for launch and accelerated scale-up of male circumcision programs, and is a strong advocate of the use of innovative service delivery models to maximize the use of limited resources available and maximum public health impact on the HIV epidemic in the region. Dr. Njumeli.
Thank you very much, Craig, for the nice introduction. Hi, everyone. It is my honor this evening to present to you the first presentation of this panel. This presentation is going to focus to summarize the editorial of the recent collection that was published by PLOS Collection in May 2014. Just to give a quick background about that collection, as Craig just mentioned, is a collection that looks at lessons learned of the acceleration of the scale-up of VMMC, looking at issues related to cost, demand creation, quality of services, and efficiency, particularly related to the surgical aspect of VMMC services. So just to give a quick background, in 2007, following the result of the 3 randomized controlled trials, WHO and UNAID issues recommendation for countries with high HIV prevalence and low male circumcision prevalence to incorporate male circumcision as part of the HIV prevention portfolio. But it is important to also recognize that in addition to the benefit of male circumcision in prevention of HIV, male circumcision do have additional important health benefits, mainly on HPV prevention, HSV2, also HPV for, there's also some benefit for female, and as we have also demonstrated in one manuscript that we published in November 2011 in PLOS Medicine, even the benefit from HIV prevention is not just for male, but also for women. It is an intervention that targets men primarily, but do benefit to the entire population, both male and female. And as you can see here on this slide, even when we look at the long-term follow-up of the cohort from the randomized control trial in Uganda, we actually see that the protective effect of male circumcision is sustained over time. And this slide shows clearly that after 5 years of follow-up of that cohort, there is some clear evidence that the estimation of the protective effect of circumcision of 60% was actually underestimated. Here we see that we have a 73% effectiveness when we follow that cohort after 5 years. In 2011, we did a modeling looking at what will be the impact of male circumcision if countries in Southern and Eastern Africa can be able to scale up the intervention to reach a coverage of 80% of male circumcised among adult and adolescent 15 to 49 years old. And we estimated that if we can be able to achieve that, male circumcision have a potential of avert almost 3.4 million new HIV infections in the next 15 years and generate potentially a cost saving of $16.5 billion. You see here on this slide how this translates country by country, with Zimbabwe, for example, where male circumcision have the ability to avert almost 42% of new HIV infection just by focusing on this intervention. These are the 14 priority countries, and you can see on this map that those countries are also the countries where you have high HIV prevalence and mainly low male circumcision prevalence. Part of the recommendation of WHO was also clear indication of the minimum package of services for male circumcision, including screening and treatment for STI, HIV counseling and testing, age-appropriate risk reduction, promotion and provision of male and female condom, and circumcision. There is one specific element of this package that was not part of the WHO and UNAID recommendation, but that was included by PEPFAR, which is active referral of HIV-positive clients to care and treatment. So you can see that it is really a comprehensive package of services when we talk about male circumcision. It's not just a surgical removal of the foreskin. So based on this background, in November 2011, in collaboration with UNAID, we published a collection in PLOS ONE that was really a signpost of the way forward to accelerate the scale-up of VMMC service delivery safely and efficiently to reap individual and population-level benefits. Following the publication of that collection and building on the information that was published as part of that collection, former Secretary of State Hillary Clinton set the goal for PEPFAR to help achieve an AIDS-free generation. VMMC was then recognized along with treatment and PMTCT as key priority intervention to help achieve AIDS-free generation. December 1st, just 2 days after the publication of that collection, President Obama challenged PEPFAR to support 4.7 million VMMC by end of 2013. And just a couple of weeks after that, during the conference at ICASA, Executive Director of UNAID, Michel Sidibe, together with former President of Botswana and former U.S. Global Health Coordinator, launched the Joint Strategic Action Framework for Acceleration of the Scale-Up of VMMC. That was really the beginning of the focus in all 14 countries to accelerate and intensify the scale-up of VMMC. So this slide shows you what was the goal defined in that particular document. The goal was to reach 20.3 million men in all 14 countries in Southern and Eastern Africa between 2012 and 2016. South Africa and Uganda were supposed to reach the highest number of men by each of them circumcising 4.3 million and 4.2 million men. So this is to give you a background of where the program comes from, and now we will be able to provide you an update of the status of the program as of now. So the current collection, as you can see, I've tried to build on the data of the monitoring data, but also various studies that was implemented between 2012 and 2014, looking at the quality of services, efficiency, cost effectiveness, and demand for services during the acceleration of the scale-up. The editorial of the collection particularly look at all the 14 manuscripts, and we were able to discuss some lessons and challenges related to managing male circumcision program in Southern and Eastern Africa. This slide shows you the event that I just mentioned, but what is here, what this slide also shows is the number of circumcision that the program have reached between 2012 and 2013. By end of 2013, PEPFAR have been able to reach the goal that was assigned by President Obama, but more importantly, all circumcision, all donors together, the program in the region have succeeded to reach close to 6 million men altogether, which is a remarkable achievement. In this slide, you can see that it is a program that have almost doubled output every single year since 2011, with 0.8 million circumcision done in 2011, 1.7 million done in 2012, and 2.9 million in 2013. This slide gives you the breakdown of the number of circumcision done per country. Please don't compare countries because it's not really, we are not able to compare these countries in terms of achievement. Some countries started the scale up in 2008, and some countries are just starting to accelerate the scale up even as we speak now, particularly for Malawi. Lesotho, for example, started to scale up in 2012. So this data does not really capture the acceleration of the scale-up that happened in Lesotho in 2012 and 2013. But however, you see that in most countries, despite the huge acceleration, there's still a lot that need to be done to reach the coverage that was set by the Joint Strategic Action Framework for the acceleration of the program. In terms of, we recently did some modeling to try to determine what is the current impact that have already been achieved by the current state of the program. Catherine is going to present in detail some result of this modeling, but I just wanted to show you these two slides showing currently in South Africa and Uganda what is the impact that the program have already generated, even if we stop the scale-up of circumcision now. By end of Q1 in South Africa and end of 2013 for Uganda, the two countries have circumcised over 1.3 million men and 1 million men respectively. And even if there were no more VMMC done after that, the circumcision performed to date will have an estimated 140,000 and 230,000 infections by 2013 in both South Africa and Uganda. And if you project further by 2050, we actually see that it is an estimated 250,000 and 630,000 infections that will potentially be averted. So it is a huge achievement already done by the program that translates clearly by a specific number of infections that the program is already contributing to avert. The question now is, where do we go from there? Look in this graph that gives you where we are in terms of trajectory. Our estimation, if the program continues at the current level of scale, assuming a flat budget, we believe that by the end of 2016, we will probably be able to perform 13 million circumcision. We will be short 7 million to be able to achieve the goal of 20.3 million circumcision. However, if we can be able to have an additional funding or be able to efficiently use the current level of resources available, we then should be able to close that gap and be able to circumcise those additional 7 million men. In terms of efficiency, during a satellite yesterday, someone asked the question, what have we learned? Two specific key things that we have learned in the scale-up of VMMC. When you look at this slide, in blue is the percentage in age group and more uncircumcised men in Tanzania, Swaziland, and Malawi. And in black is the percentage of clients in age group among those which in 2013. You see here that we have a disproportionate representation of men circumcised by the program related to the men in that age group. So clearly, adolescents 10 to 14 years old and 15 to 19 represent more than 60% of the men that the program have reached so far. Remember, the target was to reach 20.3 million men aged 15 to 49, not 10 to 49. So we do have almost 42% of men reached by the program who are among the age group 10 to 14, which is a huge proportion of the achievement of the program. And at the other end, you see that the program have not been able to reach proportionally men above age of 35 years old. So what this means for the program, some people might think that we need to intensify and invest more in order to attract older men. Some people might think that maybe we need to not pay attention to the adolescent. The answer to that in order to be able to have a clear data for countries to make decisions related to all of these questions, we have actually developed a new modeling tool, the Decision Makers Program Planning Tool 2.0, and we have applied that modeling in countries in order to understand better the importance of each of those age groups in terms of infection averted. Catherine is going to present during this satellite the result of that modeling so that you can be able to have an idea of really what is the importance of each of those age groups. What we have also learned in Tanzania, for example, through this manuscript is the cost to have a good understanding of the cost drivers of VMMC. We have learned that the key drivers of the cost are consumables, are personal costs. So if we want to be able to improve in terms of efficiency, we need to look on how to be more efficient in terms of staff time and also in terms of commodities and supply chain management, because those are the two important drivers of the unit cost. Training is a third component of the drivers of the cost. We also did an economic analysis of unit cost data collected in several countries in sub-Saharan Africa, and is clearly demonstrate that there's a lot of room for improvement in terms of efficiency as the program reach some level of scale. The programs clearly have not been able to really implement most of the efficiency that we can do to take better advantage of the limited resources. We also did a modeling looking at how we can be able to use new technologies available, particularly PREPEX device, to improve the efficiency of the program. And the key lesson that we have learned from that modeling is that we have a program that is extremely, that have a high capacity in terms of supply. For example, we have some sites that have a capacity to perform 100, 150 circumcisions per day. However, the number of clients that we receive in those sites is just 20 or 30 clients a day, which is a huge underutilization of the supply that is available. So any addition of technology in terms of to further improve the supply of the program, we need to be followed by a very concrete strategy to increase significantly the level of demand if we really want to take good advantage of these technologies that are being introduced in the program. This slide summarizes some kind of framework that we put together to look at the various elements of the program and try to understand where we can be able to improve. We have the enabling factors, and we realize that there's a strong leadership in most countries in Southern and Eastern Africa. Most countries have a clear policy for male circumcision, and the level of resources so far, we do believe that we can be able to improve the efficiency of the use of the level of resources, while we also recognize that we need to have more resources in order to reach the goal of circumcising 20.3 million male. Our estimation is a funding gap of almost $700 million. When you look at the levels for scales, we do believe that there's an improvement that can be done in terms of government program management capacity, mainly when it comes to coordinating all the resources that come together to support countries. In some countries, we have several donors, and the better donor coordination and better and efficient use of comparative advantage of all the partners can, by himself, significantly improve the use of resources. There are a lot of data for decision making. This is a program that have really built on data to make decisions. And I think we think that we just need to continue to generate data for decision making. The program currently is looking to various technologies for improvement, particularly devices. In terms of supplies, several presentations after my presentation will look at the various aspects of quality of services, the potential opportunity to refer HIV-positive men to care and treatment, and also the various efficiency that can be applied to improve the supply side. Karen Hazard will go in more detail about the demand side of the program, and the key challenge, as you can imagine, is really how we can be able to match supply with the level of demand that we have in the program. We do believe that if we critically look in every single of those aspects, we should be able to use this data and these lessons that we have learned from the first 2 years of the acceleration phase to move the program to the next phase and be able to reach that goal by 2016. This slide, before I conclude, is just to say that well, the more we implement this program, the more we learn that there are so many parameters when it comes to male circumcision. Male circumcision is a very passionate topic that generates very, very sensitive and passionate debate at community level. There are cultural aspects, religious aspects, traditional aspects, that are all very important to take in consideration, and it is important that we just always remind ourselves that this is really about the people. And maybe if we understand what those communities want, we'll probably be able to figure out how to better provide a support to those communities. Thank you.
Thank you very much, Emmanuel, for that excellent overview. I'd like to turn now to Dr. Dino Rech, who is the co-founder and joint CEO of the Center for HIV and AIDS Prevention Studies, CHAPS. CHAPS is a leading service delivery and technical support partner to VMMC programs in Southern Africa. Dino is a physician, social entrepreneur, and researcher in the field of HIV and operations research. He's led the development of the MOVE concepts published by WHO that are utilized in most of the countries implementing and scaling up VMMC for HIV prevention. He's worked and consulted to numerous international organizations and universities on public health and HIV-related topics, and has an intense interest and passion for healthcare management, and specifically how social business models can be used to make NGOs sustainable.
Thanks very much. So good evening, folks. I think the part of the discussion tonight that I've been asked to address is really one of the key and founding principles of the whole VMMC Scale-Up project, and it's around quality. When we began voluntary medical male circumcision as a public health initiative, one of the key questions related to can we implement a surgical intervention, which at the time was solely based on a scalpel, in a safe way, and can we scale that up efficiently in a safe way? And the programs, the proudest part of the program we're involved in is related to making decisions based on data. The randomized control trials that were done showed us that in a research setting, the procedure could be scaled up safely. But what we needed was real life data, data from the field, data from the scale-up, and that's what the funding agencies and PEPFAR allowed us to do in the research I'm about to tell you about. So the background to MMC, I think most of us are well aware of, but what I'd like to talk about is a research program called the CMEX program, or CIMEX. And this was the systematic monitoring of medical male circumcision. And essentially it related to assessing the quality of the VMMC program in 4 countries: South Africa, Tanzania, Kenya, and Zimbabwe, over a 2-year period. And we looked at the adoption of efficiency elements of the MOVE model, or the efficiency model, and how, as we introduce these efficiencies, things like circumcision packs, electrocautery, task shifting, and task sharing, how did that impact on the quality and the adverse event rates of our surgery? So the methodology involved process evaluation in the 4 countries mentioned. There were 2 serial cross-sectional samples done in 2011 and 2012. And it included a range of sites: fixed sites, which were specialized standalone facilities; outreach sites, which involved going to schools and halls and other remote locations to offer services; and mobile sites, which often involved a mobile vehicle or mobile structure where the surgery was actually done from within. Kenya was one of the only countries that had more of the mobile and outreach type facilities. The other 3 countries had a mix and a range of the 3 that I mentioned. So the data collection instruments involved a quality assessment tool, which was an abbreviated tool based on a WHO tool, observation of at least 10 procedures per site, which include timing of each operation. So how did the time of the operation necessarily relate to the quality of the surgery provided? And interviews with providers, both primary and secondary VMMC providers, so the actual people doing the surgery and people assisting. And what did they have to say about the surgery that was happening? So what did we find? So the first paper I'm going to talk to you about was published by Jennings and was part of the CIMAX work that I described. And she found that the amount of circumcision sites and the actual scale-up of the program, as mentioned by Emmanuel, increased markedly between 2011 and 2012. We found pronounced seasonal variation in peak periods. So in a country such as South Africa, for example, there's a winter preference for circumcision where the amount of surgeries goes up exponentially over a 2 to 3 month period. Most of the countries had adopted at least 3 to 5 of the surgical efficiency elements, which were the electrocautery, the forceps guided method, the task sharing or shifting, the use of circumcision packs. And what were the country-specific quality trends? So in South Africa, for example, especially in the initial period, we saw that the country scaled up extremely quickly. And with this fast, rapid scale-up, there were pressures on the quality, not so much of the surgery, but of the support services, which I'll get into. So Zimbabwe showed improvements over the course of the 2 years across all areas, and Kenya and Tanzania showed no specific changes between the 2 time periods. Key findings: the overall strength of the program. Group education on HIV prevention was widely available across all 4 countries. Generally, the programs did extremely well on the surgical procedure itself. So although this was a package combination prevention initiative, the surgical part scored extremely highly across all 4 countries. There were huge improvements on the information systems and gathering of data by 2012. Some of the areas that we focused on for improvement were the inadequate, in some instances, inadequate recording of adverse events. So there were gaps in the monitoring system, specifically of the complications early on. Lack of emergency equipment at some facilities, and occasionally the absence of guidelines on site. And just to reiterate, this was the early stage of the program in many countries, and a lot of the findings were used by ministries of health at specific intervals to improve on where there were gaps. There was a paper specifically published on South Africa by myself and co-authors, and this paper looked at South Africa as a country that had had one of the fastest paces and most exponential kind of scale-up paces. And the achievements were an excellent client information system, and again, good surgical technique. Once again, in South Africa, we found some gaps in terms of the monitoring systems in place for adverse events, the frequency of external supervision to the facilities, the post-operative counseling. So there were sometimes gaps in the post-operative counseling and some small issues around infection control. The elements of efficiency not yet in use specifically in South Africa was task shifting. So the other 3 countries have all shifted the surgical activities mainly to nurses or clinical associates or clinical officers. In South Africa, it still needs to be done by a medical doctor or a clinical associate, but not nurses at this point in time. So how did the countries use the data that we gathered? They had periodic meetings, annual program evaluations that were conducted using the SAMEX findings. And what this meant was the NGOs, the government, and the site management sat around a table and looked at the periodic findings of the SAMEX work to discuss how to improve services. Real-time program and policy changes were considered and implemented as a result of these meetings. Another very important part of the quality program, and something that we felt was important to mention in the satellite, is continuous quality improvement. And essentially, we looked at external visits looking at sites, but how did we integrate into the daily or monthly management of a site, a quality approach? And USAID used a system and a partner called Assist and piloted this in Uganda, where they set up specific teams to train in-house service delivery teams on quality, how to review quality, how to implement their own internal changes. This worked extremely well in Uganda, as you can see from the table, with baseline assessment statistics improving markedly in a very short period of time. Recently, South Africa has now implemented the CQI, and we're kicking off with a similar initiative looking at strengthening even further the quality of our programs and our systems. So in conclusion, scaling up VMMC programs is an important strategy in the prevention of HIV. The overall scale-up has often overextended human resources, which in turn has a negative effect on some of the original sites and the expanded program. However, with a strong focus on quality, we've been able to overcome that to a great extent. Given the potential significant contributions of VMMC in decreasing HIV transmission, monitoring quality is critical in identifying and eliminating gaps in care during introduction and the scale-up periods. And I think that in years going forward and moving forward with this program, and in future, should we introduce other surgical initiatives or other complex initiatives for public health means, this will be an important learning tool and important learning process for any of those future projects or initiatives. Thank you very much.
Thank you very much, Dino. We're going to turn now to look at VMMC program efficiencies. And I'd like to introduce Dr. Webster Mavu, Deputy Director of the Center for Sexual Health and HIV/AIDS Research, Zimbabwe. A social scientist by profession, he has around 10 years of experience conducting research. Since 2009, he has been involved in several collaborative male circumcision studies, to date having co-authored 8 journal articles on infant, adolescent, and adult medical male circumcision.
Thank you. Good evening, everybody. So I'm continuing from where Dino left and present data on surgical efficiencies and provider attitudes and experiences from the CMAX study. And I would like to acknowledge part of the CMAX team that is in here. There are some colleagues who are in here in this room. So I won't bother you with this background around male circumcision scale-up, but a systematic monitoring of the VMMC scale-up took place in 4 countries, as Dino has said. And there are 6 elements of efficiency that we explored that had been identified by practitioners. These are task shifting, which is allowing non-doctors to perform all aspects of the procedure. Task sharing, as the name suggests, allowing non-doctors to perform some aspects of the procedure, including the most important ones, which are stopping bleeding or hemostasis and suturing. We also had pre-bundling of surgical supplies with disposable instruments and kits, because other sites would need to bundle the supplies and instruments on site, and then rotation among multiple bays in operating theater, and use of electrocautery or diathermy for hemostasis versus using ligating sutures, and use of the forceps-guided surgical method. So as Dino said, this was a process evaluation conducted in 4 countries, and we conducted 2 serial cross-sectional samples of VMM sites in 2011 and 2012 using the same instruments, and Kenya was the only country that had mobile sites. So this slide summarizes adoption of the 6 efficiency elements by the end of 2012. As you can see, none of the 4 countries had adopted all 6 elements of surgical efficiency, and this may have changed. For example, Zimbabwe has now adopted task shifting of circumcision to non-doctors, So some of these things have changed since then. I would like to go into some analysis that we did around several aspects of our efficiency. And the first analysis is by Rek and others, who examined the association between elements of surgical efficiency, quality of surgical technique, and the amount of time required to conduct VMMC procedures in actual field settings. And what was found from this analysis is that two aspects of efficiency, which are task sharing and electrocautery, were associated with reduced provider time with a client, as well as reduced operating time overall. However, the quality of surgical technique was not significantly related to time spent with the client or operating time, except in South Africa in 2012. And factors related to operating time varied by country, but overall, task sharing reduced operating time in South Africa, Zimbabwe, and so did electrocautery. So this slide is just confirming what I've just said, that task sharing, which is allowing nurses to perform suturing, was associated with reduced primary provider time with client, and so was the use of electrocautery, especially in Zimbabwe. A second analysis that we did in relation to efficiencies was to assess provider attitudes towards the efficiency elements, recognizing that adherence to these efficiency elements largely depends on provider attitudes towards them. And what we found out was that there was high concordance between each country's policies and provider attitudes towards the efficiency elements. However, some providers expressed the frustration that their policies did not provide for certain practices, such as task shifting in South Africa and Zimbabwe by then. We also looked at work experience, job fulfillment, and burnout among providers. And providers in all countries reported high levels of personal job fulfillment. However, several providers reported work fatigue and burnout not only among themselves, but also among their colleagues. And burnout was highest in Kenya, which is the country with the longest running VMMC program. So this slide just also reiterates what I've just said, that providers generally were happy with their job, but as I said, most of them reported burnout, and burnout was highest in Kenya. Right, in terms of recommendations that we came out with based on these analyses, are that no amount of surgical efficiency can compensate for weak demand for VMMC services. So operating at peak efficiency yields benefits primarily under high volume conditions. And I'm glad that some guys on this panel will focus on demand creation, because this is essential. Also, countries should consider how best to support and motivate their providers to maintain job fulfillment and reduce burnout. And countries should consult providers and ensure great understanding of policies to ensure compliance with efficiency elements. I would like to acknowledge the several country team members who participated in the CIMAC study. I would also like to acknowledge other collaborators and our funders. Thank you very much.
Thank you, Webster. For the last presentation in this portion of the session, we're going to look at referral of HIV-positive clients to care and treatment. And to give that presentation, I'd like to introduce Dr. Virgil Kikaya, who is JPIGO's Lesotho Country Director since July 2014. He served previously as JPIGO Lesotho Voluntary Medical Male Circumcision Technical Director in Lesotho since October 2011, and has been working in Lesotho since 2009 altogether, first as an HIV prevention consultant for WHO and the Ministry of Health, and then later joining JPIGO's office. Dr. Kikaya has also worked as a clinical monitor for WHO's special program for research and training in tropical diseases, for UNAIDS in the DRC, for WHO's African program for psoriasis control. Sorry, difficult day. For PricewaterhouseCoopers as a Global Fund Local Fund Agent, M&E Advisor, and for the National Program for Neglected Tropical Disease in the DRC. Dr. Kikaya obtained his medical degree from the University of Lumumbashi, DRC, and subsequently a Master's in Public Health from the Free University of Brussels, Belgium, and a Master of Science in International Development and Management from Lund University, Sweden. Dr. Kikaya.
Thank you for this nice presentation, and sorry for the word on consequences. I think it's past 7, so sometimes it's hard to talk at this time of the day, especially that some of us started the day very early, like before 7. But I will try to be brief and just to take you to look at the VMMC in the perspective of a program implementer who is looking at quality of services in the perspective of referrals. Why those referrals are part or a component of quality of services for VMMC. So because it is late, I will be happy if everybody at the end of this session can at least point Lesotho on the map, because it's not evident that everybody can. So this is Lesotho right there. That tiny little red dot in the middle of South Africa is the kingdom in the sky, because it is mountainous, and that's how we refer to it. Some people refer to it as the hostage state, because it is all landlocked by South Africa, and you can imagine that they don't have a lot of room in terms of their policies if they don't have to align by what South Africa is saying. The population is more or less 1.8 million, and it's mostly rural population in Lesotho. The capital is Maseru. One of the key element of the economy is the migrant labors. So we have almost 50,000 now, official migrant mine workers, who are mostly men, of course, above 20, that go to South Africa to find work. And this is more relevant for how to get service to these people. And we have just learned from the UNAIDS recent report that migrants are also one of the key population to focus on, because they are lagging behind in terms of accessing services. And the 50,000 are, of course, the official number. There's so many other people that live in Lesotho but go find work in South Africa. In terms of the epidemic, more or less 360,000 people are living with HIV. The HIV prevalence in Lesotho is at 23%, which is now have been ranked as the second in the world after Swaziland. We have over 25,000 people new infection per year, and the TB HIV co-infection is pretty high, up to 75%. We don't really know what's the HIV prevalence among men with MSM or injecting drug users, but we have some factories in the country, and in those like subpopulation, especially made of women, you can have a prevalence up to 40%. And most new infections are coming from heterosexual transmission. So the graph on the side just shows the prevalence in men in Lesotho, and you will notice with me that from 15 to 24, the prevalence is pretty low. But from 24 to 30, 34, when those young men start working and maybe go to South Africa and in the mine, the prevalence is definitely skyrocketing to a certain level up to 40%. The response testing is still an issue for men. The last DHS shows that less than 24% of men knew their status, had an HIV test for the last 12 months. There's 60% of adult coverage in ART, and quite a good retention of patients on ART, up to 72%. But what is also key to look at here is nearly 3 out of 4 patients on ART are initiated at a CD4 count that is less than 250. And this is, we'll try to link that to the VMMC program and to why the referrals are so important in this context. The modeling studies that were presented part of the first PLOS collection shows that for the Lesotho context, 5 MCs can avert 1 future HIV infection. So this is a program with very high return. You invest in 5 circumcision and you can avert 1 potential HIV infection. In Lesotho, services are facility-based. That means we offer VMMC only at hospitals and at health centers. This is a guidance from the Ministry of Health to avoid some sort of antagonism with traditional healers, traditional circumcisers. The services are free of charge, and we offer them as part of the package of services that was presented, plus the linkages now that we're implementing. Since we started in 2012, we achieved 60,000 male circumcision, and more than 80% of the clients are under 24. HIV positive, because they are pretty young, it's up to 6%, and we have a low rate of adverse event. So what was the idea behind the manuscript, the kind of case review that we did? We looked at one hospital, and we wanted to know what was happening basically to the MC client who were testing HIV positive at the facility, at the hospital. So we went back at that hospital called Mafiteng and just look at the data and see if all clients that tested positive actually presented at the ART clinic, or did they have a CD4 count, and were they enrolled in treatment at a certain point. And for those who we could not find in the ART clinic, in the registered ART clinic, we tried to trace them through phone calls after that. We noticed, first of all, one of the key findings was that 65% of all male tested in that particular facility were coming from the VMMC program during the same period. I think this is really showing that male circumcision remains one of the key PITC program in Lesotho, especially for men. In this context, when men actually don't test, VMMC is a pretty good opportunity for them to know their status. But more interesting, when we looked at the people who tested positive, those who could be identified at the ART clinic, 62% more or less were traced and were actually enrolled in care and treatment at the clinic. And more than 50% were actually already eligible for treatment at that clinic. So those were people that were walking around with not knowing their status and maybe continuing to transmit and to pass on the epidemic. So for those who did not did not receive a CD4 count on the day of diagnosis, for a reason there was like a problem at the lab, the CD4 machine was not working, 16 of them could not be traced. We could not find them. We didn't know where they were. And 15 of the 15% that we managed to find, only 5% reported having been enrolled in sort of care and treatment in another facility. So 9%, almost 10% of those said they don't have time, they will go later, they have other things to do. So this was clearly showing us that having a client who tests positive and received a CD4 count on the day of diagnosis were likely to enroll in care and treatment. And that gave us like room for advocating and starting putting point of care CD4 machine at VMMC site. But also we looked at other component of this quality of services, looking at hospital staff. You could see that some of the staff that were initiating ART and were working at the VMMC clinic had were more willing to actually ensure that these clients were referred and were enrolled into care and treatment. One of the key components also was the review of VMMC data and to compare it with the data at the ART clinic. So we managed now to kind of we held ourselves accountable by having an indicator on referral to HIV care and treatment. So definitely, as a quick conclusion, VMMC provided a health facility present an opportunity to increase HIV diagnosis and, of course, to link those clients to treatment and care. But it requires some investment in terms of supporting the counselors who are doing this job, in terms of trying to trace the clients that are testing positive if they can't access immediate CD4 counts, but definitely providing them that opportunity of accessing CD4 count, it's very important. And this morning when I was when we were in the session, the plenary, on the state of the art epidemiology, I was pretty struck to see that in that study where they were looking at those adolescent girls that were HIV positive, only 2 cases were actually were traced from the school. Most of the people were from the community, older men who are working, maybe they are coming from Lesotho, and they are infecting those girls. So I think it's very important for us to catch those men, to bring them to services, and to link them to care and treatment after giving them another prevention service. Thank you. And this as the co-author, and I would like also to thank our donor. Thank you.
Thank you, Virgil. So we're going to pause there now, having had an overview of the VMMC scale-up effort overall, its effectiveness, where we are at with targets, achieving targets, demand, and some of the current funding issues, and then 2 presentations that looked at the CIMAX in studies in South Africa, Tanzania, Kenya, and Zimbabwe, looking at both quality issues and program effectiveness, and then looking at Lesotho and what's going on in terms of clients of VMMC who test HIV positive and their referral to treatment and care programs and some of the challenges and opportunities there. Can we take some questions from the floor, comments? Don't be shy. And please state who you are, where you're from, what you do.
Okay. I'm Eric Oma. I'm from Malawi. From the 4 presentations, I've noticed that there's one thing that is missing, and that is from the literature that actually suggests that men are not really comfortable being circumcised by women. But then I noticed that I think one of the pictures there was actually showing that there were a lot of women involved. I think this must be the one from South Africa. So what I'm wondering is whether literature that is showing that men are not comfortable being circumcised by female providers, whether that literature is really slipping under the radar, that researchers are not capturing it.
Webster, do you want to maybe take a crack at that?
So from studies around acceptability of female providers that we've conducted in Zimbabwe, men have not raised this issue. They say we come to the clinic anyway to be treated for other ailments, and the nurse is the nurse who administers the injection to us. So really it hasn't been an issue. I don't know in other settings.
I can just add that a similar kind of experience from South Africa. We haven't had, some men have expressed preferences for women providers, but others have expressed for male providers, but others have expressed preferences for women providers, for female providers. So in South Africa, we haven't seen a specific pattern around that.
But actually, there are almost 4 studies that have been conducted in SADC, published, and all of them talk about women not being comfortable with men. Women actually providers. So maybe that's something that needs to be, we need more research, maybe in that area, actually just literature review, simple.
Sure. We'll take another question. Right down in the front, number 1.
Well, thank you very much, moderators, and thank you very much, the presenters. I'm called Samson Chironde from Uganda, and my question goes to the program in Lesotho about especially using VMMC as an entry point into HTC service provision. Now, when you have such high levels of HIV prevalence, like there in Lesotho, like you mentioned in your presentation, I'm just wondering what the perceptions of the men who actually want to take up circumcision are, because normally we sort of tout circumcision as something that is responsible, or we want to use for HIV prevention, 60% protective and so on and so forth. So if I'm already HIV positive, or if I think I'm HIV positive, why then do I want to go for circumcision? If men have that perception, like, as you mentioned, especially the ages between, was it 24 to 35, very high prevalence, and they basically think that circumcision is going to help them, don't you think that that impedes them from coming for the service, other than actually allowing them as an entry point into HTC, as you mentioned, so that they can receive care and treatment? Thank you.
Thank you for the question. For Lesotho, maybe one of the cultural aspect of the country is this is a country that have a culture of traditional circumcision. So there are people who don't want to go to the tradition in the mountain where they have to stay for 6 weeks, but are willing to come to the service because there's still this common understanding that when you are circumcised, you are a man. So we are receiving, even though there are, some of them don't know, most of them first don't know their status, so they come not knowing their status. And when they get to the clinic, that's why they are offered mostly HTC by the counselor. And because, I think it's because they're comfortable, they're like in a group of men, some of them decide that it's the day to get tested. Sometimes we kind of say men don't want to be tested, but when you look at the facilities, I'm sure in Lesotho, but it might be also in other places in Africa, when you go to in the morning in a facility, it's crowded by women. You'll have like women with babies, women with at OPD. So men have that feeling that going to the health facility is not something for men. Men don't go to the facility unless they're very sick. They don't go. So coming for the VMMC services because they want to be circumcised, because it's somehow related also to the tradition of being a man. It's pretty something that they do easily, and when they get there, they are offered HIV testing and counseling. And we have noticed that in more than 95% of the case, they accept to be tested.
Thanks, Virgil. Just a follow-up to that. Your presentation showed a pretty bad cascade in terms of the number of men that were lost to follow-up from the time they tested positive, being referred, CD4 counts, initiated on treatment. So, and yet you concluded by saying this is obviously a great opportunity for increasing care of HIV-positive men through the VMMC program. Thoughts on improving that cascade?
Absolutely. I think one of the assumptions that we made at this time is because this service was being offered in a hospital, then people who were coming for the service were actually being referred automatically. So when we went back to reviews, because we wanted to ascertain that assumption, but we really realized that it was not always automatic, that people who test positive at the VMMC clinic that is also located within the hospital under one roof are actually getting to the ART clinic or are actually being enrolled into care and treatment. So that's why we try to identify what could be the key element that can contribute to improve this cascade. And definitely one of them was, for instance, having CD4, point of care CD4. We have had cases of clients that totally were clearly telling you, why are you referring me to another counselors to introduce myself as an HIV positive when I'm already here and I'm comfortable with you? Why don't you continue? So those are the kind of things that we looked at. It's more than 60% were referred. This is pretty good. It is not really that bad, but definitely there's room to improve and to go beyond that number.
Please.
The gentleman up there was first. I can come second.
Okay, so we'll take one more question from the floor. Number 3.
Okay, my name is Alex Samona from PSI SFH Zambia. And my question is mostly looking at the quality. keeping the balance between the quality of services offered versus the huge numbers that we have just seen going on in the various countries. I don't know the experience from maybe Dino in other countries that is there in terms of having the quality, keeping a balance between having quality services versus the huge numbers that the programs are planning to achieve. Because when you look at the most resource-constrained countries, and especially those countries that are very much dealing with outreach-based service delivery model, you find that there is a lot of compromise out there in the rural setups in terms of having the quality services that you can give, such as infrastructure and other systems that need to support the quality. So here, I would want to learn from other countries and really from the panelists how we see going forward we can have to strengthen the quality of the way the services are provided in the countries.
Thanks. I think one of the issues or one of the challenges we've had to work through is that the regional quality tools and even some of the existing tools were very much focused on a conventional kind of surgical approach, which included a theatre with theatre lights, etc., etc. And one of the concepts we've had to get our heads around is how to adapt those so that quality is not compromised, but that outreach and hard-to-reach settings and the circumstances we work in can still be of a high quality, but you may have a headlamp or you may have something else that's not a theatre light but provides adequate lighting, as a small example. So I think we shouldn't be compromising on quality, but sometimes the quality tools don't exactly fit the settings we're working in. And just in terms of massive and rapid scale-up that's very quick, you could see from the findings in South Africa that we did have challenges in certain areas keeping up. But I think as the program progresses and we build strong systems, especially the operation systems, they become easier to implement at scale. And I think that's what we're looking for.
I just want to add on what Gino just said, that on the Ministry of Health perspective, both the Ministry of Health and the donor perspective, quality supersedes the volume. So I think that is very important to understand, that we shouldn't sacrifice on quality just because we want to reach huge number of men. And for us, in order to make sure that we have a high quality services provided to the clients, we have systematically introduced some processes in the program. One of them is a frequent external quality assessment that is being conducted by an interagency team in various countries, looking at a snapshot sample of sites. And those EQA have actually allowed us to identify systemic quality issues and be able to address them. However, we have also learned quickly that these EQA will not be able to allow us to have high quality services in every single site, because that's really what is about. There's the introduction of continuous quality improvement processes that Dino mentioned in his presentation. That process was piloted in Uganda last year, and we have some very interesting data showing that how all facilities that have received intensive support through the partners for implementation of continuous quality improvement, where you really have the staff as facility level constantly assessing their own services, identifying the quality gap, and coming by themselves with some clear understanding of what they need to do to improve, and reassessing themselves constantly. So we have that process that we will continue to roll out toward the program, and just make sure that we have a high quality services in every single site. So just wanted to mention that for the program, both Ministry of Health and donors perspective, quality is of high importance as we roll out the program. Now this is the good things about quality improvement. We have also realized in Uganda, for example, with the implementation of CQI, that those sites that have achieved high confidence in terms of their ability to provide good quality of service are also the site providing high volume. So somehow, good quality also improved in terms of volume.
Thanks, Emmanuel. I think Karen Hatzel, you wanted to come in?
No, I just had a quick question to Virgil. Thank you very much for your excellent presentation. There has been a lot of or more critique towards the male circumcision programs in different countries to stigmatize against HIV-positive clients. And I just wanted to get from you the perspective from Lesotho of what you're doing with HIV-positive clients, especially since you are also offering CD4 account on site. So for those who might not be eligible for treatment, those who are on CD4 account above 350, how do you deal with these clients if they insist they want to get circumcised?
Thank you, Carrie. We do not put the knowledge of the status as a precondition to get circumcised to avoid actually this discrimination. But definitely all clinicians that are providing the service, because it's a doctor-led program still, have the mandate to kind of, if the person doesn't want to be tested, to kind of assess by clinical if there is any sign in the WHO clinical staging, and then they won't circumcise the person. They'll just tell him, you know, you have been maybe sick, just get treated for, and it's like the same way when you have STIs. I mean, the person come and then we say you have STI, you can't be circumcised today. So we do not put it as a precondition so that we avoid that discrimination, definitely.
Thanks, Virgil. I think we'll move on now to the second part of the session, which is focused on some of the modeling work on VMMC and EIMC recently. And I don't think it was deliberate we had all the men in the first part of the panel and all the women in the second part of the panel, but it just worked out that way. To give an overview of some of the modeling results on age and geographic prioritization, specifically looking at Tanzania, Malawi, Swaziland, South Africa, Uganda, Zambia, and Zimbabwe, I'd like to introduce Dr. Catherine Kripke, Senior Health Policy Advisor who joined Futures Institute in 2012 after over 20 years experience working on HIV and TB in various capacities. She earned a PhD from Stanford in immunology and completed a 3-year postdoctoral fellowship. Dr. Kripke also worked as an AAAS Science and Technology Policy Fellow in the Office of HIV/AIDS at USAID, and at USAID served as Senior Technical Advisor for HIV vaccines and microbicides, and on the PEPFAR core teams for Kenya and Tanzania. At Futures Institute, Dr. Kripke's main focus is the USAID Health Policy Project, where she is Activity Manager for VMMC, costing and modeling activities. Dr. Kripke.
Thank you for that welcome. I want to thank the organizers for inviting me to speak, and I want to thank all of you for foregoing your dinner hour and for staying awake. So thank you for coming. How do I get the slides up?
Click on your...
Okay. Okay, great. So this is the one talk that doesn't actually have anything to do with the PLAS collection. We hope that it will be published sometime over the next year, but this is a kind of a sneak preview of some of the exciting modeling that we've been doing over the past year. So some of the context, as of 2013 when we started this, the 14 priority countries for VMMC were about a quarter of the way towards reaching the global targets that had been set. And we're starting to consider additional questions that might be addressed by modeling. For example, they were interested in how to improve the programs to achieve greater efficiency, greater impact, and to address questions that were coming up having to do with age and geographic prioritization. So Emmanuel showed you this slide in his talk. one of the things that was observed was that although the global targets were for men between the ages of 15 and 49, they were seeing large numbers of 10 to 14-year-olds coming in unsolicited for VMMC, and so there was a need to consider what the contribution of clients of this age would be to averting HIV infections. And the clients over the age of 25 were coming in disproportionately less to compared with their distribution in the population, and so there was a thought that clients over the age of 25 were very important because of intergenerational sex, and so it was important to circumcise those because they were contributing, it was thought, a lot to the epidemic. So the question was, how important is it to circumcise clients over the age of 25? And so we created the new DMPPT2 model. So just why is it DMPPT2? There was a model called DMPPT that was created back in several years ago, and which was applied and resulted in those projections that people are referring to, about 3 million HIV infections averted over 15 years by scaling up to 80% MC prevalence among 15 to 49-year-olds. So we created the next generation of this model to really enable us to look at age disaggregated targeting of clients, which the first model was not able to do. So it's tracking clients as they age and tracking men in the population as they age and altering the HIV incidence projections based on the circumcision prevalence of different age groups. And it enables the user to put in different strategies for age targeting and look at the results of that. So this is kind of the dashboard of the model, and you can see that in the blue column, the user has entered an age targeting strategy whereby circumcisions will be scaled up to 80% prevalence between the ages of 10 to 49 by 2018. So the user can input any numbers in that blue column as long as they're greater than the numbers in the white column, which is the baseline MC prevalence by age, and that's the baseline prevalence is generally gathered from survey information for each country. So in the right panel here, this is using Tanzania as an example. If you look at the years starting in 2014, those are the circumcisions that would need to be achieved in each year for each age group in order to reach the targets that are set in the table on the left. And for the years 2013 and before, those represent the program circumcisions that have been conducted already. And so you can see that in Tanzania, if they continue to scale up at the rate that they've been scaling up to date, they should be able to meet their targets by 2018. After 2018, the country will still need to continue to circumcise males in the lowest age group of their strategy. In this case, with the strategy shown here, it's the 10 to 14-year-olds. So they'll need to continue to circumcise those males in order to maintain the 80% prevalence in that age group that they've set. So every model has limitations, and I'm going to put these up front for your consideration. This model is very sensitive. The projections of impact are very sensitive to projections of HIV incidence. And whenever you're projecting something into the future, particularly what's going to happen with the HIV epidemic, there's a lot of uncertainty. So it's the actual numbers of HIV infections averted are highly dependent on the assumptions that you're making about the incidence trends going into the future. And when we're making subpopulation projections, those are based on historical prevalence data that lead into incidence projections for whatever subpopulation you're looking at, and there are limitations on the availability of prevalence data by subpopulation, and so we may not be able to do analyses for every subpopulation that is of interest to the country. We often get asked, for example, can you do this analysis for truck drivers, or can you do this analysis for this city, or something like that. And in general, there usually aren't enough historical data in order to do a projection for that population. We can do them on the national level. In some cases, we can do them on a regional level, subnationally, but going finer than that, usually the data are not available. And that said, if you were to conduct similar modeling exercise for any prevention intervention, it would be subject to these same limitations about the assumptions that you're making about incidence and the availability of data. So this isn't anything that's really specific to VMMC modeling. It's just kind of a limitation of any modeling that's based on incidence projections. And then secondly, any model is populated by inputs that are themselves subject to uncertainty. So for example, the baseline male circumcision prevalence is based on surveys, which has a certain level of uncertainty, and the unit costs may be, not known, or they may be uncertain. So those are other limitations. Another important point to discuss before we get into the modeling itself is that when we apply this in countries, we're very careful to not present the model results as as dictating the strategy of the country. We really want the countries to engage and use the model results as one piece of information that will inform their age targeting strategies, but their strategies will also be based on a number of other types of information that have nothing to do with what's coming out of the model, and we want to acknowledge this up front and be very clear about it. So, for example, countries will consider human resource considerations, space considerations, demand creation, other benefits of the VMMC platform, such as what we heard about from Lesotho, and then policy realities. For example, in some countries, it's very important for there to be geographic parity and programs, things like that. So these are all equally valid considerations for a country when they're considering their strategies. So when we conduct a country application, we need to collect the following data in order to populate the model. We start with the national spectrum AIDS impact model or goals file. So these are models that are set up for each country, and they're part of, when UNAIDS comes out with their projections of the HIV prevalence and incidence for the country, in collaboration with the ministries of health, they actually create an AIM file, and in some cases they have goals files. I'm not going to get into the details about the difference between those two, but we're starting with validated national projections of HIV incidence and prevalence and population. And the data that's coming from those projections is downloaded and input into the DMPPT2 model. We also start with the percent circumcised in the base year, and this is coming from country surveys, usually the DHS or the AIDS indicator surveys. And we also need program data with the age distribution of circumcisions performed in each year. And we need either data or assumptions about the unit costs of circumcision and treatment. And then we need to have the country agree on what discount rate we're going to use for the analysis. So I'm going to walk you now through the age targeting analysis, and this is a roadmap for the age targeting analysis. So there are, on the left, what you're seeing is 4 different lenses that we can put on the age targeting analysis. So for example, the first one is what we're calling, for the sake of this analysis, effectiveness of VMMC. And what we're defining that as for this analysis is how many circumcisions do you need to do to avert one infection? And that's related to the HIV incidence in that population. The next one is the immediacy of impact. So with the particular age targeting strategy, how quickly is incidence reduced? The next one is the magnitude, really the long-term magnitude of impact. So how much, over the long term, how much reduction in HIV incidence do you have with any particular strategy? And finally, we look at questions of cost, total cost, and cost effectiveness. So there's no formula that leads from these 4 parameters over to what we're kind of calling programming efficiency. And in some cases, different stakeholders will put different priority on different ones of these metrics. So for example, in South Africa, they said, we're really concerned with immediacy of impact. That's our highest priority. Whereas, a donor might say, cost effectiveness is absolutely the one thing that I want to focus on. And so usually countries will kind of through discussions among the stakeholders come up with their own way of breaking down how they're going to translate the results into their age targeting strategy. And then down at the bottom of the slide, again, this is just a nod to say that the modeling is really only a part of the conversation. So we're going to walk through each one of those metrics. So here we're looking at the number of circumcisions per infection averted, and I'm using Malawi as an example here. So what you're seeing is each bar represents a fictitious age targeting strategy where you're only scaling up circumcision to 80% among that particular age group. And then over time, they're going to remain circumcised and they're going to age and they're going to be protected. And you'll have infections averted across the entire population as a result of circumcising clients of that age group. So what you can see here is that the highest effectiveness or the lowest number of circumcisions per infection averted occurs in Malawi when you target clients between the ages of 20 to 34. And this corresponds with the ages just before the peak incidence in Malawi. So if you were to look, I don't have this in this talk, but if you were to look at the distribution of HIV incidence by age, it's between the ages of, say, 25 and 34. So now we're going to look at immediacy and magnitude of impact. So you can see that the incidence comes down the fastest when you target the age groups 25 to 29, which is the brown line there, and the 20 to 24, which is the blue line. So again, this corresponds to where the peak incidence is, or just before the ages of peak incidence. And then if we look at the long-term magnitude of impact on incidence, you can see that those are between the ages of 10 and 19 for Malawi, or maybe you might also include the 20 to 24-year-olds. So, and this makes sense because over the long term, even though, for example, the 10 to 14-year-olds, the impact is going to be delayed for them. If you look at the green line there, you can see that in the early years, you're having a delayed impact on incidence. In the long term, they're going to be protected for the largest fraction of their lifetime of risk. So if you catch clients before the sexual initiation, they're going to be protected for their whole life, whereas if you circumcise clients, for example, at the age of 35 or 40, you're only protecting them for a fraction of their period of vulnerability. So now, I know that this is a very busy slide, so I apologize for this, but we're going to look at cost and cost effectiveness. And I'll just draw your attention to the bottom left panel first. So this is cost per HIV infection averted. And each one of these bars represents a particular age targeting strategy. So the bar at the top there is our baseline for this analysis, which is targeting 10 to 49-year-olds. So we're just setting that at 100% for every one of these metrics. And then we're comparing that with different strategies. So we're starting with targeting 15 to 24-year-olds, 15 to 29, 15 to 34, and then 10 to 24, 10 to 29, 10 to 34. So these are examples of potential age targeting strategies that a country might adopt. And what you can see here is that the most cost-effective strategy, which means the lowest cost per HIV infection averted among the ones shown, is by targeting ages 15 to 34. And so if we look at where the little orange arrows are, you can see that by targeting 15 to 34-year-olds, the cost per infection averted is 78% of what it is by targeting the 10 to 49-year-olds. If you move up to the graph above that, that's the HIV infections averted. So you can still avert 86% of the HIV infections averted with this age targeting strategy, and you only have to do 60% if we move over to the scale up MCs. You only have to do 60% of the circumcisions during scale up to achieve this target. And then the total cost is 66% of what it would be if you were targeting the 10 to 49-year-olds. So it just shows you that you can achieve some increased efficiency. And then we also were looking at the impact of adding lower and lower age groups. And this is in response to the question that people had about how important it is to target older clients versus younger clients. So in the top line here, you're seeing a strategy of targeting 30 to 34-year-olds, which were thought to be a very important age because of intergenerational sex and because of high prevalence among that age group. If you add the 25 to 30-year-olds, then you have increased impact. And then if you add the 20 to 24-year-olds, you have even more increased impact over time. And then likewise, if you add the 15 to 19-year-olds and the 10 to 14-year-olds, you have the maximum impact. So the more clients that you circumcise at a lower age, the greater your impact is over the long term. So we've applied this model in 5 countries so far, and we hope to also be applying it in Lesotho. And what you're seeing here is a summary of the best age groups for each of the indicators that I just discussed for each country. So in terms of, if we just look at the different indicators, the lowest number of circumcisions per infection averted is usually between the ages of 15 or 20 and then 29 to 34 across the different countries. There's some variation because of the differences in baseline circumcision rates and also differences in incidence across the countries. You can see that for immediacy of impact, it's usually the 20 to 29-year-olds that give you the greatest immediacy of impact, with some plus or minus 5 years for the different countries. For the magnitude of impact, it's pretty much the 10 to 19-year-olds across the board, and that's basically because of the age of sexual debut. The cost effectiveness is usually 15 to 29 or 15 to 34 as being the most cost effective age group to target with these particular assumptions that we used. So Malawi and Tanzania have already considered these results and used them to inform their age targeting strategies. So Malawi has decided that they were going to focus on 10 to 34-year-olds to maximize, all of those different metrics that we looked at. And Tanzania already had a strategy of targeting, focusing on 10 to 34-year-olds, and they felt that the results of the modeling confirmed that they were targeting the most appropriate and impactful age groups. And then the other countries are still undergoing discussions about the implications of the modeling. So now I'm going to, I'm at time, okay. I'm not going to do this because I'm at time, but I'm going to instead invite you to come and see my poster on Thursday, where I've actually talked about the geographic targeting in Malawi. And so come see my poster and we can hear about geographic targeting, which is very exciting. And I'll just say the conclusions is that we've applied this in several countries, and the countries are selecting their targets. And I'll just leave it there. So thank you everyone who contributed to this, thank you, this exercise.
Thanks, Catherine. Excellent work. We'd love to hear the rest of it. But we do need to move on. I would like to introduce now Dr. Karen Hatzel, Deputy Director of Programs for PSI in Zimbabwe and Director of the Gates VMMC Partnership Project. Dr. Hatzel is a public health physician with over 15 years' experience in managing, implementing, and researching public health efforts in sub-Saharan Africa. Over to you.
Okay, thank you very much, Greg, for the introductions. And thanks very much for the organizers to give me the opportunity to speak at this panel. I will speak mainly about the three demand creation papers that were included in the PLOS collection, but I give also a quick overview and introduction to demand creation and why demand creation is so important for VMMC scale-up. I would like to acknowledge also Kim Seifert-Ahander from USAID and Elizabeth Gold, who had contributed to this presentation. As we all know, VMMC has set, the VMMC program has set a very ambitious goal to reach 20 million male circumcisions by 2015. And for this, sustained demand is essential. In no other health program, uninterrupted supply and continued support for demand creation is as important as for VMMC. There also needs to be a balance between demand and supply. If supply outweighs demand, we have lots of wastage in terms of human resources that could be used for other health services, for vital other health services. And the other way around, if we are having too much demand, if we're creating too much demand and there's not enough supply, we're also frustrating clients and are deterring clients from male circumcision services if these are not available. We have to create and we have to tailor-make our VMMC demand creation activities based on evidence. We have to understand the barriers and motivators in the different countries in which we are implementing VMMC services, and then being very creative and innovative for our demand creation activities and strategies and adapt them to the context. VMMC is also specific because it is not only dependent on demand creation for communications, but it's also a VMMC communication continuum. So as we have said already, VMMC is not only the surgical procedure, but it's also a prevention intervention, a package of services that has at each step included counseling to prevent risk compensation, counseling to ensure that people are not starting sexual activity during the healing period, and so on. So VMMC is also very specific in terms of communication and guaranteeing a communication continuum. Some of the countries have also adapted VMMC service delivery and have created, demand creation has to be adapted to the service delivery modalities. Many countries have implemented VMMC campaigns and increased intensity of service delivery and demand creation during certain periods of time, school campaigns, for example, or provided outreach services. These are more generally, this is based on research from Zimbabwe, but I think these are mainly the barriers and motivators that we're also seeing in other countries. Major barriers to VMMC uptake is the perception of pain during the operation, the fear of the operational complications, the fear of an HIV test, preventing people to take up VMMC, especially in high HIV prevalence countries. There were still in the beginning myths and misconception what male circumcision means. People had the perception that it's sterilization, was conflict with understanding that this is male circumcision or not sterilization. People had conceptions as well that this would reduce the sexual drive. Partner refusal and female partner refusal with especially married men or older men has been one of the deteriorating factors of uptake, especially in older men. Then people are also pertained away from the abstinence period, the long abstinence period, of 6 weeks. And there are obviously cultural and religious factors who are preventing some men for uptake of VMMC. In terms of the motivator, most people are motivated for the HIV and STI prevention benefits, but more and more we're seeing also people speaking about the hygiene benefits of male circumcision and the other benefits of male circumcision, like reduction of cervical cancer incidence in the female partner. Sexual performance has been mentioned as well, especially in Zimbabwe, as one of the motivating factors for VMMC, because there's a perception that sexual performance, sexual appeal is better with male circumcision and it's more appealing to women. And also being part of a group, so having really that social moment that being circumcised is the norm and belonging to that group is one of the motivating factors that we have seen. Some of the demand creation activities and approaches that have been used, obviously, and this is very multifaceted, community mobilization, supported by mass media and social media, mHealth, especially also on the social media, especially for younger clients. I have mentioned already school campaigns that are initiated by schools, promoted by headmasters and teachers, workplace mobilization for older men, peer education and support using VMMC champions and engaging traditional and political leaders. So now in the following 5 minutes, I will speak about the 5 abstracts or manuscripts that have been included in the PLUS collection. One paper on VMMC in Tanzania and Zimbabwe, looking at service delivery intensity and modality and the influence on the age of clients. The second one is a paper from Zimbabwe, looking at the barriers and motivators and the age-specific motivators and barriers for VMMC. And then the third paper is a paper from Kenya from qualitative research on older men in Turkana. So the first one is based on a case study, on 2 case studies from Tanzania and Zimbabwe. This was mainly based on secondary analysis from these case studies, looking at stakeholder, in-depth interviews with stakeholders, as well as looking at programmatic data from these 2 countries. And specifically, interest was in looking at how the 2 different countries have used campaigns specifically to increase uptake of VMMC, and looking at the age-specific distribution of clients who are taking up male circumcision during campaign and also during routine service delivery. As you can see here, and this I'm showing you the slide from Tanzania, the graph from Tanzania, you can see that about 65% of the overall number of clients are actually accessing the services during campaigns. Campaigns in Tanzania are mainly provided during winter over several months. And as you can see here as well, in the younger age group, as compared to routine service delivery, which is the light blue, many or more, about 70% of the younger age group were actually reached in campaign mode or in campaign service delivery, as compared to the older men who mainly much less accessing services. As you can see, much higher number in the younger age group than in the older age groups are accessing VMMC services, but also older men are mainly accessing services during routine service delivery. This is mainly due also to the perception or during the way that campaigns are conducted, mainly on outreach, and that is already emphasizing actually more the barrier to uptake of services by older men. And also probably these younger age groups are also much more receptive to peer support and peer pressure, and uptake is much higher. We're seeing similar trends in terms of age distribution for campaigns in Zimbabwe, but the reasons for this are very different. So about 70% of clients that are reached with VMMC are reached during campaigns, and about 80% of that age group, the younger age group, are accessing the services during campaign. But this is mainly because campaigns are mainly targeting women, school-going children, are mainly conducted during school holidays, and provide a higher opportunity for younger age groups to access services. So very important to understand is that formative research is really important to understand the cultural preferences in the different countries, and campaigns can be used in different contexts in different countries, and social norms should be used to guide design for service modalities for VMMC scale-up. Just quickly, again, showing you that slide from Zimbabwe and then also from Tanzania, you can see that on the left-hand side, you see that this is the number of or the client distribution by age group. And this on the left-hand side is the age pyramid. And as you can see here in Zimbabwe, looking at the distribution of those who have been reached with VMMC, you see actually more or less an equal distribution in terms of percentages of people reached in the different age groups. Very different now from Tanzania, where you can see that really still very large numbers or percentages of the very young age groups, up to 20% are reached, while actually in the older age groups only 1.3%. So different cultural contexts. Yes, I'm going. In terms of Zimbabwe, we have, just quickly going on the barriers and motivators that were very age-specific. In Zimbabwe, just to summarize the results, there were differences in the motivators and barriers amongst different age groups, while most clients from the two different age groups were mainly motivated because of HIV prevention benefits and STI prevention benefits. There were differences in terms of under other attributes to male circumcision, like sexual appeal, a perceived sexual performance in older men that motivated them to go for male circumcision. In terms of the barriers, especially women and men with partners feared that their female sex partner was not interested in them getting circumcised because of the risk of risk compensation and them being unfaithful after male circumcision. So very important from Zimbabwe, the message was really adapting the communication campaigns to the age groups and also to emphasize on non-HIV prevention benefits. And also to involve women in the communication campaigns. I just need 1 minute more. I just want to quickly show you what has been done in Zimbabwe based on these results from the research. So we have used famous musical celebrities and radio personalities to increase social support for male circumcision, and these celebrities function as role models. Also promoting the non-HIV benefits for VMMC, personal hygiene, reduction in risk cervical cancer screening for the partner, and also addressing the issue of pain, which came up as a major demotivating factor for male circumcision. Very quick slide on the Kenya study from Turkana, which was mini qualitative research that was done among older men in Kenya, in the Turkana men. What came out there is that the major barriers to uptake of VMMC was a stigma against a foreign culture, low risk perception amongst the older men, that male circumcision, that they were at risk of HIV infection, the cultural norm because it was not done in that culture, and the major facilitator was to desire to be modern, to protect against HIV, better hygiene, and also to be a role model for older men. What came out very clearly as compared now to the results from Zimbabwe is that in terms of communication, the HIV prevention benefits should be really coming out very clearly in the communication campaigns to also separate this from the cultural practice. So in summary, in terms of the key recommendations that came out from the research is that communication should be informed by evidence, that there needs to be constant monitoring and adaptation of communication strategies, seeing what works, what doesn't work, and throw it overboard if it doesn't work and adapt something new. Consider the cultural and social norms that are very different in the different country, and also to tailor approaches by the age segment. The messages should be based on motivators beyond HIV prevention, looking also at the female benefits in terms of prevention of cervical cancer, the sexual attributes, the other social attributes to male circumcision, and to involve peers and influencers in the audiences, also specifically women. And early ongoing community engagement is very important to ensure that there's community buy-in. School campaigns are effective in countries, but for different motives, and also to distinguish health benefits from VMMC from traditional male circumcision as that was shown in Kenya. Thank you.
Excellent, thank you, Karen. So our last presenter on adolescent VMMC assessment is Lynn Van Lith, who has over 20 years experience and is currently working as a senior technical advisor in HIV and AIDS with Johns Hopkins Bloomberg School of Public Health Center for Communications Programs under the Health Communication Capacity Collaborative Project. Before that, she served as the Senior Technical Advisor on Behavior Change Communication and the HIV/AIDS Technical Advisor on the Health Communication Partnership with the International HIV/AIDS Alliance.
Thanks,
Over to
Craig.
you.
And thanks to everyone for sticking around. I promise to end in 10 minutes or less, given the hour. We've heard a lot already about the growing number of adolescents coming for VMMC services. And so the question that we're asking ourselves under the HC3 project is, what do we know about the needs of adolescents, really? So I want to acknowledge, first of all, Dr. Aaron Tobin, our principal investigator from Hopkins. There are a number of other people involved. What I'm presenting tonight is just a very small sliver of a literature review, which represents the first phase of a much larger adolescent VMMC assessment. I also want to acknowledge our technical advisory group. This really is a team effort. We have representatives from the Office of the Global AIDS Coordinator, CDC, DOD, WHO, UNICEF colleagues, and the Bill and Melinda Gates Foundation. So to date, this technical advisory group has really weighed in quite heavily, not only on the literature review, but in terms of providing insights and their opinions in terms of developing the instruments for the larger adolescent assessment. So I really want to acknowledge them and the support from PEPFAR. So while we've heard that there are a growing number of adolescents coming for VMMC services, there's remarkably little known about the quality of that service delivery for young men. And we know that reproductive health and HIV prevention services have typically targeted women, as they should, and everything we've been hearing at this conference and before highlights the vulnerability of young women, so this is absolutely in the right direction. But in the process of doing this literature review, we really found that there's a dearth of information related to adolescent boys in particular. So what we want to do is try to learn a little bit more about quality VMMC services and recognizing that this is an important opportunity to engage young men. So our goal through the assessment more broadly is to gain a better understanding of whether VMMC programs are adequately meeting the needs of adolescents in age-appropriate ways. And this is really important. I mean, if we're looking at the age group of 10 to 19, a 10-year-old boy who is not yet sexually active has very different counseling needs from a 19-year-old young man, for example, who may already be sexually active. So the purpose of this assessment is not to look at the clinical aspects of service delivery. A number of other colleagues and partners are doing that already, but to really focus on in-service communication and counseling and try to see what's happening there. So the proposed study countries include, ideally, South Africa, Tanzania, Zambia, and Zimbabwe. So again, tonight I'm presenting just a very small sliver of the literature review, which is the phase 1, and I'll speak about the other phases at the end of this presentation. So we worked with a librarian at Johns Hopkins School of Public Health and went through these various databases to look at the peer-reviewed literature published after 1990 to date. And I don't have time to go into all the search terms, and given the hour, I don't think anyone would be interested. But these are the key constructs that we explored. And again, looking at boys and young men really at the center of that. There's an incredible amount of literature on adolescent health services and youth-friendly services more related to girls, but again, not as much focusing on young boys. So the literature review also looked at specific programs targeting adolescents, and certainly looked at anything related to VMMC that pulled out any data related to adolescents. And the search really focused on sub-Saharan Africa. So these are the criteria for inclusion in a literature review. Each article had to include at least one of the following, including the differences between adolescent boys and girls. Again, sometimes this information is combined and not really reported separately. Looking at VMMC services, analyze provider, educator, parent, and adolescent perspectives on quality, and again, really discuss VMMC. So we looked at around 1,000 articles, the abstracts were screened, and then from there, we narrowed it down to 226 articles that were given a full text review. So there were 2 readers for each article, and if there were any disagreements about whether or not to include them, they were discussed and finally agreed upon. So in the end, we had 88 articles for inclusion in this synthesis. In addition to that, we deviated a little bit from the norm and included 6 practical guides from WHO and PEPFAR, and also, thanks to our country counterparts, several unpublished papers that are equally relevant were shared with us, and those are also included in this literature review. So I should state as well, these are still somewhat preliminary in that several of the countries were still waiting for their feedback, but the report is in draft form and we should have a finalized version very soon. So again, I'm not going to focus tonight on any of the general adolescent reproductive health data that came through, but again, just focus in on a very small sliver of the VMMC specific findings for adolescent boys. So what do we know? What does the evidence tell us? We know that the role of parents, families, and educators is incredibly important. In Zambia, for example, one study showed that parents were the first source of VMMC information for 61% of adolescents, and even in non-circumcising districts, many parents said that they would take their sons for VMMC if they knew more about it. In Tanzania, many fathers who would not get circumcised themselves said that they would indeed take their sons. And again, this was mentioned at the satellite last night that Chapaigo sponsored, that women play a really important force, not only in terms of supporting their husbands in going for VMMC services, but certainly for their sons. And that said, another study from Kenya very clearly pointed out that while parents and all of these other people have an influence on adolescent boys, of course adolescents still need to and must make that final decision themselves. Some of the barriers that prevent parents from taking children, and Karen mentioned some of this as well with the behavioral determinants in her presentation, fear of pain is a major issue that's listed not only for parents but also for the adolescent boys. Tribal and religious aversions were mentioned in a study focused on Tanzania, and then cost. This came up in South Africa, in Zimbabwe, not just cost for service, but the transportation and other opportunity costs do certainly play an important role. Another study, again, focused on Tanzania, that parents in some of the tribes thought circumcised sons would be embarrassing in areas that are not traditionally circumcising. And then in South Africa, among Xhosa men, this is in an area that does a lot of traditional circumcision, that while knowledge of voluntary medical male circumcision is widespread, only 16% of the fathers would actually encourage their sons to undergo the procedure. And when looking at what young men know or what some of their misconceptions or motivators are, this came up quite frequently in terms of, we still have limited evidence, but in many of the articles, real concerns about what it means after circumcision. Will you still be able to get a woman pregnant? Will it affect sexual satisfaction and sexual desire? Very real issues that certainly need to be addressed. Again, the issue of some traditions and rituals which may be missed if a boy were to undergo voluntary medical male circumcision, and a remaining lack of understanding of the protective factors. In a study in both Zambia and Swaziland, most of the boys reported not being very comfortable with VMMC prior to the procedure, and this is after counseling. Likewise, in Rwanda, after counseling, 37% of the adolescents could not identify what was taking place in the procedure. So even with counseling, it does suggest that there may be some areas for improvement. And with respect to counseling, again, in Zambia and Swaziland here, comprehension of the procedure was much lower among adolescents than adult men. This is one of the few studies that separated out some of the information. And so this also is sort of cause to pay attention to. Likewise, adolescents found that some of the pre-procedure counseling was very effective, yet there was significant confusion about the protective factors, and this was measured on a 10-question test. So in summary, given how little evidence is actually out there, it's very difficult to make broad-reaching conclusions about what the evidence tells us. But we do know that parents play an important role in the decision-making around male circumcision. In South Africa, VMMC in clinical settings lack some of those traditional components, so some men are missing out. And that retention of information among young clients from the counseling is often incorrect. And this is a point, I think, which is really important for us to pay attention to. And clearly further research and study is needed. So I mentioned the adolescent VMMC assessment, and this phase 1 literature review is just the first step. There are 2 other phases planned. The first is a qualitative phase with 6 instruments, actually, a combination of focus group discussions and in-depth interviews. And then the third phase is quantitative in nature, which includes surveys with both clients, with providers, and some observations. So with that, in under 10 minutes, thank you very much.
Excellent, Lynn. Thank you, and incredibly important work. I think we will take a few questions. I realize we're almost at 8:30, but I think it's important to give people the opportunity. Tim, is that Tim? Yes. Yeah.
Great, yeah, Tim Mastro with FHI 360. Fantastic presentations. Question for Catherine. Really nicely presented model, and not clearly a very well done model. One assumption that I'd like you to verify, I'm assuming the number of circumcisions you're talking about are circumcisions among HIV negative men. Is that correct?
Yeah.
The model doesn't distinguish between HIV positive and negative clients. So that's one of the differences between this and the prior model. And this was actually a decision that was made during the design phase of the model, because WHO does not recommend excluding HIV positive clients from services. So we made no assumptions that they were excluded from the scale-up strategy.
So in that case, for a country-specific, whatever the prevailing prevalence was in that men of that age stratum, those were the number of circumcisions that were done.
Yeah.
Okay, good. Well, the next question was, how does the model handle risk compensation or risk enhancement if there's some perception of protection for the men? And there was a presentation this morning, a well-done oral poster from an investigator from the University of Cape Town that presented in South Africa a very common perception among women that women had direct protection benefit if a man was circumcised. So that raises the issue, if HIV positive men are becoming circumcised and women in the community perceive themselves to be protected, then there could be an enhancement. Does the model deal with enhancement or risk compensation?
No, this is actually quite a simple model where the model is basically tracking incidents. So it's not a behavior-based model. There's another model that was created, sponsored by the Gates Foundation and created by some researchers at University of Qatar, and it's called ASM, which is a full-blown behavior-based compartmental deterministic model. And they are able to look at questions such as risk compensation in that model, but our model is quite simple.
I wouldn't call it simple. It's actually quite nice. Thanks.
Thanks. Microphone number 4.
Sten Vermont, Vanderbilt University. Both at yesterday afternoon's session and today, we haven't heard much about infant circumcision. Could you comment about what are the opportunities in when you're building momentum and you're building demand creation for getting the infant sons of these many men and the women that you're getting involved, getting them circumcised? What is the bridge between adult and infant circumcision in these programs?
I think that's a very good question. Mainly, one thing that I did not mention is that in 2012, it was strategically decided that the program should focus on adolescent and adult circumcision, mainly because we wanted to reach sexually active men in order to have an immediacy of impact, but also because we strongly believe that we can be able to, through a catch-up intervention, reach high coverage in those men. So we knew that we needed, in order to maintain that high coverage that can be obtained through the catch-up of circumcision, we needed to have a strategy for sustainability. More and more, and through the modeling information that we have, we see that sustainability will be either through early infant circumcision or adolescent, depending or not if countries introduce early infant circumcision and bring early infant circumcision to scale. Tomorrow, there is a satellite sponsored by PSI, FHI 360, and Pop Council at 6:30, and that satellite is going to address specifically early infant circumcision. Catherine did not mention data related to the modeling on early infant circumcision on purpose because these data will be presented during that satellite tomorrow. So more on this will be discussed and presented during the satellite tomorrow at 6:30 p.m.
Can I just add on as well, Craig? Can I add on?
Please.
Sorry. I think a very good question, and as Emmanuel said already, there's this satellite tomorrow where we're speaking specifically about the perceptions and motivations for perceptions for parents that they had their baby circumcised. And just based on the evidence that we have from the current studies that we have conducted in Zimbabwe with early infant male circumcision, we're seeing a high number of men who had been circumcised themselves bringing their sons for circumcision. So I'm sure that there are lots of opportunities to create synergy between the two programs.
And just to add a little bit, a different twist to this, about 3 months ago, UNICEF hosted with many of the people here a global consultation on EIMC in the context of HIV held in South Africa. And we also brought together our child health colleagues. One of the challenges with this, with a commitment to support countries to begin to look at EIMC in high prevalence countries, this is kind of balanced against some concerns in the child health community that the newborn period is the area where we're not seeing, where we're seeing the worst, the most mortality and morbidity in infants. So trying to balance the efforts to scale up a global newborn initiative to address that with the HIV priority around HIV prevention and EIMC is going to be somewhat tricky and not necessarily impossible to overcome, but something that I think we in the HIV world need to be conscious of in terms of the challenges in some of these countries around newborn deaths and morbidity in that period. Let's take a question from number 3.
Thank you. I have a number of questions, but I'll start with the one on the use. In a country such as Malawi, which is where I'm from, we have about 98% of our population subscribing to one form or fashion of faith. And if we were to reach, if you're gunning to reach at least 100% of the population, it's wise to use the faith-based approach. I haven't heard any one of you talking about the faith-based approach and using the faith system in demand creation for VMMC. Secondly, there's something about this particular program that I'm sort of uncomfortable with, the whole VMMC thing. It came on board, but it feels like it's at the whole lightning speed, as if you're going into countries where some cultures are aversive to circumcision, and there's this speed and these numbers you have to get on board that sometimes I feel like there's no room for cultural understanding and adaptation in a very humane way. In that regard, that's why you're seeing things like numbers changing on themselves, because the society will do what the society wants to do. So you're going to find 10-year-olds coming for circumcision, because traditionally in a lot of cultures, that's when 10-year-olds go to get circumcised. It's embarrassing to be circumcised at 20 in most cultures. So I'm trying to ask for creative ways that we can sort of get the age group that we're going to get the most scientific efficacy out of it to come to circumcision, when culturally it's embarrassing to be circumcised at that age. Another point is, in terms of the modeling, I'm very interested in figuring out how the efficacy transponds with ART coverage. With good ART coverage, how do you really assess the efficacy of VMMC, scaling up VMMC? Because we have to do a cost-benefit analysis of some of these approaches. Thank you.
Okay, I think there's about 4 or 5 questions in that question. But maybe Karen, do you want to kick off?
I will quickly speak about the faith-based organization or faith-based communication involving faith-based organizations or churches. Perhaps it was not mentioned in my presentation, but getting input or getting involvement from traditional leaders and to which below also church leaders, I think is also one of the very important various ways of demand creation for VMMC. And we have done this in a couple of countries where we have involved church leaders to speak about male circumcision and the benefits of male circumcision. And in countries where the churches, everybody belongs to a church, I think church leaders are very important advocates for male circumcision and have been used. Perhaps it has not been presented in my introduction to demand creation, but this is definitely also one of very good opportunity involving community leaders, religious leaders, and so on. I think the cultural embarrassment, I think that came out a bit in the study that I presented on Tanzania and the difference between Tanzania and Zimbabwe. While in Tanzania, there are very strong cultural norms for male circumcision at a young age and older men feeling embarrassed to get circumcised at an older age. But we don't see this in all countries. And as I presented from Zimbabwe, we don't see these cultural perception that men should be circumcised at a certain age. And this is why you actually see that the male circumcision program has reached or the same percentages in different age groups. So it is really very much dependent on the cultural context of the country, and I think we cannot generalize this. This is why we said it's very important to understand the barriers and motivators in the different countries, to understand the cultural norm, and to adapt the demand creation activities towards, or strategies towards, the cultural background and the norms in these countries.
Thanks, Karen. Emmanuel, I think you wanted to have a stab at this concern around the ambitious targets and pace of acceleration versus the cultural resistance.
Yes. Well, I'm not going to feel guilty about the ambitious target because one thing for sure is it will be a missed opportunity if we have an intervention with such high efficacy like male circumcision and we don't use it to really achieve the goal of reducing incidence as soon as possible. So that's the reason why I will not feel guilty about the ambitious target. However, I completely agree that, and you see the last slide of my presentation was very clear, it's really about the people. As part of the recent published UNICEF collection on achieving and HIV prevention, care and treatment for adolescents, we actually look specifically at what you mentioned, and we were trying to understand the importance of adolescents 10 to 19 years old, not really in the modeling on qualitative data point of view, but to look at all of those cultural aspects, traditional aspect and religious aspect. It's very clear, the data very clear. In all countries in Southern and Eastern Africa, most men prefer to be circumcised before the age of 13. So it's not by chance that we actually see that the majority of the clients that the VMMC program is attracting is actually among the age 10 to 14 years old. So it seems like this is just a natural age for those guys to be circumcised in those communities. Most older men, through qualitative formative assessment that was done, don't see really VMMC as important for them. However, we also know that because of the intensity of demand creation that was done by the VMMC program, we have seen those social norms being changed. Yes, there are social norms that we need to understand, that we need to use an opportunity, but we also do believe that if we want to be able to achieve high coverage with the VMMC program, we should also be able to use all of these data to see how we can change some of those social norms. We were discussing about early infant circumcision. One of the key and important elements that will allow us to actually scale up early infant circumcision is actually that change in terms of social norm in countries where parents are not used to circumcise their infant. Well, they will be asked to do so. That will really require a strong change in terms of social norm. So I just encourage you to look into the UNICEF collection that was recently published just before this conference, because we really extend in detail in those aspects, particularly related to the adolescent 10 to 19 years old.
Thanks, Emmanuel. And finally, Catherine, if, on the question of how the VMMC modeling takes into account the trends and projections in countries for ART scale-up.
Thanks. I'll invite you to come and see my poster on Thursday, which actually addresses that specifically for Malawi. And just quickly, I'll say that in Malawi, we looked at two different scenarios, one where treatment coverage was maintained at the current levels, projected into the future, and one in which it was kind of a very optimistic scale-up scenario where all adults with CD4s below 500 were provided with treatment, and it was scaled up to, I don't know, 80 or 90% coverage. So even in the most optimistic treatment scale-up scenario, the VMMC program, while it was slightly less impactful than the no treatment scale-up scenario, it was still impactful, and it was still cost-saving in Malawi. And I also want to say one other thing about, we've had a lot of discussions about that very same question that you asked. And one thing that I want to say about this is that male circumcision is like a vaccine. You only do it once. There's no boost. It costs less than a vaccine. And so even if you are projecting treatment being scaled up and treatment as prevention, I always worry as an immunologist, what if there is an epidemic of drug-resistant HIV? Then, this whole treatment as prevention phenomenon is at risk. And so if you have circumcised males, you essentially have half of the population with a partially effective vaccine already there that can help protect from, from any horrible things that might come up as we continue to scale up treatment. So I personally think, and it's one of the most cost-effective HIV prevention interventions in the entire suite of available interventions. So I believe wholeheartedly that it needs to be scaled up. Okay,
I want to thank this panel for their incredible insights and work, and for staying an extra 15 minutes, and thank all of you as well, and enjoy the rest of your evening.
Thank you.